Introduce to you our speaker today, and no ulterior motive. This whole thing is about Medicare. I have known David for, well, let's just say over 40 years. We used to play softball together on a traveling team, and so we go way, way back, and you couldn't find a better guy that you can trust your health care, well, not your health care, but health care information than Brother David Bowen. And so at this time, I'd like to introduce him, and his son back there is working with him, getting into the business. And so why don't you make welcome today David Bowen, all the way from the Clarkston area?
Auburn Hills.
Auburn Hills area.
Clarkston,
so
sure.
Welcome, and take your time.
Thank you.
Amen.
Thank you. I appreciate everyone who's taken the time to come out here this morning. We're going to do this presentation on changes to Medicare for 2025. My seminars are typically very informal, and I'll do my best to be as concise as possible so that I can get through this information in a timely manner. I told Pastor Fairfield that I could get through this information in about 30 minutes if I don't go down any rabbit holes. I could do a 4-hour presentation on Medicare because there's so much information. But I'm going to keep it concise to the changes that we're facing here for the 2025 plan year. Again, my name's David Bowen. A little history on myself. I worked as a pastor and school administrator for about 28 years. I've been in the Medicare industry, the insurance industry now, for the last 10 years, with a primary focus in Medicare. So I often tell people that this line of work is close to ministering to people without being a minister, because you find people who are in need of information and they have issues, and you're able to step in and kind of give a little bit of guidance to that. So again, we appreciate your time in being here today, and we're going to go through these changes to Medicare for the plan year 2025. There we go. So number one, this is not a sales presentation, okay? I'm not here to sell Medicare. I'm here to do an educational meeting to educate. So Medicare has very strict guidelines on what we do during presentations. In a sales presentation, those have to be submitted to CMS, and they have to approve everything that you talk about. So in this meeting, of course, it's strictly educational. We won't be talking about specifics as far as plans go, but it'll be a high-level overview of the changes that we're facing in the Medicare space for 2025. So, so again, this is an educational seminar. We've got some topics that we're going to go over today. I don't know if you're able to read that, but we're going to talk about enrolling in the Medicare process. Is there anyone here who is not yet enrolled in Medicare, but you're nearing that? Okay, so we have some people, and you're approaching. So you're aware of all the phone calls and all of the mail and the marketing that you get, it being a 64-year-old. I'm 61, and I get Medicare calls constantly. I was on the phone with a coworker the other day, and he said that his dad had received 18 phone calls the day before from people trying to enroll him in a Medicare plan. So just so that you know, and this is one of those rabbit holes that I'm falling off into right now that I told you I wasn't going to do. It's illegal and against CMS compliance for someone to call you without your permission. So if you get a call from anyone, you don't have to listen. I tell all my clients, soon as they start, you just hang up. You don't try to reason, you don't try to explain, you just hang up. And then you have to do that again and again because they'll keep calling back. If you block their number, they'll call back from another number. The national sales centers are, it's a feeding frenzy for those that are in the Medicare space. So we'll touch briefly on the enrollment process. We're going to talk a lot about the legislation that's been passed that affects us this year, and some of the things that have come out of that education or that legislation. There's an M3P payment plan that's been offered this year. We'll talk about some changes that are happening in the Medicare Advantage space, as well as the Medicare supplement plans. Medicare has 10 of those different supplement plans. We'll touch on hospital indemnity. We'll talk about dual eligible members who are both Medicare and Medicaid, and as well as chronic special needs plans. And then lastly, we'll talk about the low income subsidy, which is also called extra help through Social Security, which is offered to everyone who's within that income bracket. So what is Medicare? So Medicare, of course, is that insurance program, that federal program that is for those of us who are age 65 and older. It's also there for people who have a disability. And once you're on disability for 24 months, then you'll automatically be enrolled into the Medicare process. So it's the insurance that we have here in the United States that covers those of us as seniors. There's 4 parts to Medicare. So original Medicare that began back in the 60s is what's known as Medicare Part A and Medicare Part B. So Medicare Part A is the hospitalization portion. And Medicare Part A will come to you at age 65, and it will come to you premium free if you've worked 40 quarters or 10 years here in the U.S. That portion of the Medicare comes to you. It's premium free, but you've paid for it in advance because your FICA taxes over the 40 years that you worked paid into that system. So Part A covers your hospitalization. Medicare Part B is the medical portion of original Medicare. So Part B has a premium associated to it. In 2024, the premium for Part B is $174.70. And that premium will come directly out of your Social Security check each month, or if you're not enrolled in Social Security yet, you'll be billed quarterly for that payment amount. The premium to Part B changes each year. We did have one year back in 2019, I believe, where the premium actually dropped from one year to the next. But each year it goes up typically. And it's usually not a large increase. Having said that, last year's increase was quite a large bump. But the years before that, it typically was less than $10 a month in the increase in that premium. So again, this seminar is on changes to Medicare for 2025. This is our first seminar in the cycle that we're doing. We've got 15 of these seminars scheduled right now, and it looks like we might end up with about 20 before it's over with. But the information for next year's Part B will not be available to us until after October the 10th. So once the new numbers come out, we find out what the Social Security increase is for the next year. we find out what the Medicare Part B premium is, and we find out what the deductible is for Part B, and then we pass that along to our clients. So anyways, the increase as far as the Part B premium will come out sometime mid-month of October. Part D, so Part A is hospitalization, Part B is medical. So medical is anything that happens to you outside of the hospital. Part A covers everything that happens to you in the hospital. So Part B will cover outpatient procedures, it will cover doctor visits, it will cover diagnostic testing. All of those are billed under Part B. That's original Medicare, Parts A and Part B. Part D is the drug portion. So Part D came about in 2003, late in the year of 2003, December. Congress legislated Medicare Part D. So it was fully enacted by 2006, and it is the drug benefit that we have with Medicare. Now, for those of you who are in the pre-enrollment process, Medicare requires that you enroll in Part B and that you enroll in Part D when you're eligible. If you do not enroll in Medicare Part B or Medicare Part D when you turn 65, then when you do enroll, they're going to hit you with a late enrollment penalty. So it's very important, even if you're not on prescription medications, that you enroll in Medicare Part D when you're eligible, because the late enrollment penalty can get expensive, especially later on in life. So A, B, and D are Medicare. You see the fourth portion up there, and Medicare likes the alphabet, right? You're going to see that throughout this presentation. They like the alphabet. Medicare Part C, again, came about in 2003, 2004, because Medicare on its own covers 80%. So there is a 20% copay. And we'll talk about how people originally covered those copays through Medicare supplement plans, but not everyone was eligible for a Medicare supplement plan. You had to qualify medically through an underwriting process in order to get into one of those plans. And then they're often very expensive. And so not everyone could afford a supplement plan. So 2003, Medicare Advantage came out, and it was labeled as Medicare Part C. So Medicare Part C is a combination of A, B, and D, all rolled into one plan. And then those plans are operated by private insurance companies. Those plans also include additional benefits that aren't included in Original Medicare. So Original Medicare, for example, does not cover dental. It does not cover vision. It does not cover hearing, which is crazy to me because the older we get, what happens? We lose our teeth, we lose our eyesight, and we lose our hearing. And Medicare says, no, we're not covering that. It's just crazy to me, but that's the government, right? Is this being recorded? We can take that out, right? So Medicare Part C, Medicare Advantage, is a combination of A, B, and D rolled into one plan. Those are the commercials that you see on TV, the commercials that have all the additional benefits and all of the things that they're trying to entice you with. Because Medicare Advantage plans, Medicare Part C, Medicare Advantage, those plans do have additional benefits that aren't included in original Medicare. So you are going to get a dental benefit in a Medicare Advantage plan. You are going to have vision coverage, and you are going to have some hearing coverage, in addition to other things. I mean, they'll load transportation into it. They'll put a quarterly OTC, over-the-counter benefit. So those things are included in Medicare Advantage. So those are the components of Medicare. You either have original Medicare Part A and B, or you have a Medicare Advantage plan. So as we begin with Medicare at age 65, or if you're on disability that 24th month, you're going to go into Medicare and you're going to receive your Medicare card Part A and B. Now, if you're already in the Social Security system, the Medicare enrollment process is automatic, because Social Security is going to communicate with Medicare, and they're going to tell them this person is turning 65 on such and such a date. And so you have, you're going to just get a Medicare card in the mail. If you're not collecting Social Security benefits, if you're not part of that system, then you're going to have to go to ssa.gov, and you're going to have to enroll in Medicare. And it's a very simple process. You can call the 800 number, and you'll be on hold for about 2 hours, and then they're going to tell you to go to ssa.gov and enroll. If you have trouble with technology, you can't enroll, and you don't want to be on the phone, you can go to your local Social Security office and wait in the lobby for 2 hours, and then they'll tell you to go to ssa.gov. No, they'll help you with that enrollment process. So if you have any questions on that whole scenario, or if you need any assistance, of course, you can certainly reach out to us. So once you are enrolled in Medicare Part A and Part B, you've got two different paths, because you have to have some coverage. Medicare covers 80%. The 20% is not capped in any way, shape, or form. So it's 20% of whatever the bill is. And if you've had any experience with the medical field, you know how large those bills. I was talking to a client 2 days ago, and he was telling me about a neck surgery he's having next month. And he said his doctor told him, you'll be in the hospital for 1 day and expect a bill for $80,000. So it's very expensive to be in the healthcare system. Medicare covers 80%. You've got that 20% copay. So in original Medicare, you have to have some supplemental coverage. The deductible for Part A is $1,635 this year. That goes up each year. So when you go to if you just have Medicare Part A and Part B, if you go to the hospital, then you're going to pay $1,635 before Medicare covers anything. So you're automatically out of pocket that deductible. If you go and you use the medical services, you have a 20% copay in those medical services. So it's very important that you have some additional coverage. Now, your two paths here are number one, to choose a Medigap plan, a Medicare supplement plan. Medicare has 10 different supplement plans. They're lettered A through N. Again, they like the alphabet. And then those supplement plans cover various portions of that 20% copay. So if you have a Medicare supplement plan with original Medicare, then you need to also make sure you have a Part D drug plan. And again, that is going to be a separate plan that you'll get according to your prescriptions. The other path that you have is to choose a Medicare Advantage plan. Again, Medicare Advantage is just going to be the hospitalization, the medical, and the drugs all rolled into one plan. Those plans are going to be operated by private insurance companies. Again, this is an educational seminar, not a sales presentation, but I will tell you in this service area, there are 7 different Medicare Advantage plans that are offered. Those 7 companies offer 46 different plans. I did check, and we're contracted with all of the companies that offer Medicare Advantage in this service area. The enrollment periods that you have available to you during Medicare. The initial enrollment period, for those of you who are in that pre-enrollment stage, you have a 7-month window that begins 3 months prior to your birth month, the month you were born, and then it runs 3 months after your birth month. You have that 7-month window that Medicare gives you to enroll in Part B and enroll in a Part D drug plan. Again, if you don't enroll at that time, there are stiff penalties. Medicare Part B has a 10% late enrollment penalty. Of course, each year the Medicare premiums go up, and so each year that would be readjusted to whatever the new 10% is. The Part D late enrollment penalty is a little thick in the process, but it's 1% of the national drug price average, and it's billed to you for each month you did not have coverage from your 65th birthday going forward. So just for example, my grandmother was 90 years old, and she did not have a Part D drug plan. She'd been on Medicare since the 90s. The Part D program came out in 2003. She didn't pay attention. She didn't enroll. So when we tried to enroll her in a Part D drug plan in 2013, her late enrollment penalty was $90 a month. Well, her prescriptions only cost us $100 a month, so it didn't make any sense, right, to enroll in a drug plan at that point. But it's important, of course, that you enroll during this initial enrollment period. The general enrollment period runs January 1st through March 31st each year. That is for people who missed the initial enrollment period, or maybe for those people who had other circumstances in life. You have that general enrollment period, and if you take advantage of that, then your Medicare will begin the first of the next month. So that's the general enrollment period. Of course, the annual enrollment period is this season that we're approaching right now. The annual enrollment period runs each year from October 15th through December the 7th. And it's during those 56 days, I believe, you have to choose a plan for the next year. Now, if you're in original Medicare with a supplement plan, then you're shopping for a drug plan. Medicare supplement plans are not subject to the annual enrollment period. You can change those at any time of the year. But your drug plan is something that you have to check during the annual enrollment period. And we're going to talk about some changes that happened in the drug space this year and why it's very important to look at those during this AEP season. Those that are in Medicare Advantage plans, you have this period of time between October 15th, December 7th to choose a plan for next year, okay? The open enrollment period happens on the heels of the annual enrollment period. So the open enrollment period is January 1st through March 31st. It coincides with the general enrollment period. During this open enrollment period. Those people who want to make a change in their Medicare Advantage plan can do so. So let's say you answered a call from one of the call centers and they said, hey, we have a plan for you and we want to enroll you in this plan. And you said, no, I don't want the plan. And then they still enroll you in the plan. And so you find out on January 1st that you're in a plan and it's not your plan and you need to make a change. So Medicare gives you this open enrollment period. It's an opportunity to make one change in your plan for that year. So, and it's only open to people who are in Medicare Advantage. Now, you see the PDP, or the prescription drug, is also included in that. You don't have the ability to change your PDP plan or your prescription drug plan during the open enrollment period, but you have the ability to leave Medicare Advantage and go back to original Medicare. And if that is your election that you do during the open enrollment period, then you have the ability to go out and choose a prescription drug plan. So that's what happens during that enrollment period. The Medigap open enrollment period is not used quite often, but it's 6 months from the time you enroll in Part B. This is typically going to be used by people who maybe had Part A and didn't have Part B because of work. Because if you work full-time, sometimes your HR department, like let's say you're going to work until you're 70, you're not retiring at 65, and you have a corporate insurance benefit, well, they may move you to Medicare Part A for your hospitalization, but keep your Part B with the corporate health insurance. But let's say you retire from that company and now you need Medicare Part B, they give you this enrollment period to enroll in Part B at that time without penalty. Lastly, there are special enrollment periods that happen throughout the year depending on various circumstances, okay, in life. And we'll talk about a few of those as we go through this. I know this is going to be a little hard to read at this point, but we're going to talk about Medicare supplement plans here very briefly. So we've got plans A through N, and I'm flipping back and forth because we got A through F on the first screen and we've got G through N on the second screen. But these are the 10 Medicare supplement plans that Medicare offers. Now, originally, back in the day, you can kind of maybe not pay too much attention to A, B, and D is a fairly new plan. Plans C and F were the Medicare supplement plans that everyone went to and everyone used because those plans covered 100% of everything that Medicare didn't cover. Plan F, you see the 100% there, and that is in the box of Part B excess charges. So Part B excess charges are charges that can be passed along to you by a physician who does not accept what Medicare offers them as payment for the service. That's a Part B excess charge. They can bill you 15% higher than what Medicare pays. Medicare tells us that only about 2 to 3% of doctors in the country charge excess charges. So that really was not a game changer in these plans. But plans C and F covered 100% of everything that Medicare didn't cover. Covered the Part A deductible, that $1,635 deductible that comes from the hospital. Covered the Part B deductible. So the Part B deductible comes from the doctor's office, and it's a smaller deductible, and it's an annual deductible. So Part B is billed from the doctor, and this year it's $240, okay, is the Part B deductible. Plans C and F covered both of those deductibles, all right? The Part A deductible, and this again goes back to the conversation of whether you need some sort of supplemental insurance. The Part A deductible, that $1,635, can be billed to you multiple times throughout the year because it's a deductible that's tied to a service time, okay? Medicare says that when you're enrolled or when you're admitted into the hospital, there's a 60-day benefit window that opens up. And if you're in the hospital and then you're discharged, and if you're discharged for more than 60 days, then if you go back into the hospital, Medicare Part A will bill you that deductible again. So theoretically, you can be billed that deductible of $1,635 up to 6 times a year if you were lucky enough to time it right. Now, if you're in the hospital and you're discharged and you go back into the hospital before that 60-day window closes, then there is no additional deductible because you're in that 60-day benefit period. And then if you're discharged again and if you go back in 2 weeks later, there's no more deductible, okay? But once you're out of the hospital for 60 days, then that deductible gets charged again. Medicare supplement plans cover that deductible, so you don't have to worry about it. They also covered the deductible for Part B, which is the one that's charged from the doctor. That's just a one-time, once a year. Once that $240 is satisfied, you won't pay it again. Now, plans C and F, the Cadillac plans that everyone had, those plans closed in 2020, so no new enrollments can go into those plans. And the reason they closed is because back in 2015, there was macro legislation, and buried in that legislation was the stipulation that Medicare beneficiaries need to pay their own Part B deductible. So Congress enacted that Medicare Part B deductibles would no longer be covered in Medicare supplement plans. Now, if you're in plans C and F, you could stay in the plan. So we still have people that are in those plans today, although no new enrollments are going into the plans. What we see in plans C and F is we see an exponential increase in the cost of the premium for those plans because there is no new money going in, the population's getting older, there's more expenses, and so the plan a lot of times is not feasible for people. Now, if you're in plans C and F and you need to make a change, then what do? This next group of supplement plans, G through N, again, we'll focus on the G plan and we'll focus on the N plan because these were created to take the space of plans C and F. Plans G and plans N cover everything that original Medicare does not cover, including excess charges. The only thing they don't cover is the Part B deductible. So if you're in Plan G,
quick question.
yes.
How do we know, like, what plan you have priority health? How do you know if it's A, B, C, D, all the way to N?
Okay, so the question is, how do we know what plan we have if it's priority health?
I'm hearing you say this, but I'm not understanding. I don't know what plan we have right now.
Okay, yep. And so what may be the case? You may be in a Medicare Advantage plan. You have Advantage. Okay. So if you have a Medicare Advantage plan, then you don't have any of these plans.
Okay, sorry.
Yep, you don't have any of these plans. Medicare Advantage is the cats and Medicare Supplement is the dogs. Okay? They're all pets, but they're different.
I'm trying to figure, I'm like, all right, well, I don't
Yeah.
know if I have D, or C, or F.
Yeah. Yeah. And hopefully at the end of this, we'll, I'm going to answer some questions, but I'm probably going to cause a lot of questions too. So, no, you're fine. If you have a question, raise your hand and spit it out, because chances are someone else has that same question. So these plans are for people who have original Medicare. These plans come with
Call the red, white, and blue card.
the red, white, and blue card. Yes, the red, white, and blue card, the A, the B, the 11 digits that identifies you. It gives you your Part A and your Part B effective dates is on that red, white, and blue card. These plans complement, or these plans cover the copay, the 20% copay. Now, plans G and N are the plans that we're using today, okay? For people who want a supplement plan, we're using plans G and N because, again, they cover everything that Medicare doesn't cover, with the exception of that Part B deductible. And you're going to pay that directly at the doctor's office. The difference between G and N, because they're both the same in their coverage, the only difference is that with Plan N, you will have a copay at the doctor. And it's a $20 copay. So if you see your primary care doctor, you're going to pay them $20. Now, depending on who you are and where you live, the premium for that plan might be $50 or $60 a month cheaper than Plan G. But you're going to pay that copay at the doctor. In Plan G, the only thing you're going to pay is the Part B deductible. Now, what we're seeing, and let me just throw this out because, again, we're talking about changes. What we're seeing this year, we've seen up to a 20% increase in the premiums of Plan G. And the reason we're seeing that is because everyone's going into that plan. And the medical loss ratio in Plan G right now is kind of off the charts. So people, we're feeling a lot of effects from COVID, and this is one of those effects. Yes, sir.
Yeah, reference your plans up there. Well, you referred to Plan G or Plan N. Are those plans specifically offered by Medicare, or are those plans that would be something that Blue
Yep,
Cross?
very
Humana,
good. Yep.
Do they offer that same plan, and is it titled Plan G?
Yep, that's a very good question. So the question for those of you who are watching this, I know this is being recorded, so for those of you who are watching this, is who offers the supplement plans? Is it Medicare or is it a private insurance company? And the answer is it's a private insurance company. Okay, private insurance companies offer the Medicare supplement plans. And we probably have 150 different companies across the country that are offering these plans. Now, the difference, and this is a very good question, the difference between Plan G, between Blue Cross and Plan G with Priority Health and Plan G with Greek Catholic Union, it doesn't matter. If they offer Plan G, it's Plan G. So it doesn't change from company to company. One company cannot have Plan G with benefits that another company does not. So Plan G or Plan N or C or F or any of the other alphabet soup is the same from company to company. The only difference is the price you pay. And that's very important because when I go to a search engine and I pull up my plan, my Medicare supplement plan offerings for a 65-year-old male, they're going to range, anywhere from well, I don't know, we've got price increases, but last year I would have said they're going to range anywhere from the $130 range up to the $300 range for the same plan.
And we're paying that in addition to our $170 a month of our Medicare that's already coming out.
Yep,
correct?
and the supplement plan is in addition to the Medicare Part B premium that Medicare grabs from your Social Security check before you get it. So those two figures, plus the Part B deductible of 20%, of $240, plus the cost of your Medicare Part D drug plan is going to be the cost of your Medicare health insurance from month to month. So you've got to add those three figures up. You're looking at the Part B premium plus the Medicare supplement premium plus the premium for your Part D plan. And that gives you the cost of Medicare. We're seeing Plan N is more stable right now because not that many people have used it. Again, it's got that $20 copay at the doctor's office. But if you're healthy and you're not seeing the doctor, monthly, some people just see the doctor annually. Some people see the doctor a couple times a year. If you were seeing the doctor 2 or 3 times a month, Plan N is not your plan because the savings that you get will get eat up in those copays. So those are Medicare supplement plans. Any questions on those plans before I move on?
Really?
Yes, sir.
You keep talking about D and then the cost if you're late getting to the party.
Mm-hmm.
I think we have D, and I think it's under $10. I want to say it's like $3 or $4 a month. But going late, you say it's $90 a month?
No, that was the cost for my 90-year-old grandmother. So the late enrollment penalty is 1% of the cost of the national cost of the prescription drug plan. Okay, the prescription drug plan last year was, say, $35 a month. It's going to be more this year. But if we look at that, it's going to be 0.35 cents per month. It's not a lot. But if you haven't had it for 120 months, you're in the dollars at that point. So what they do is they take the number of months that you did not have Part D coverage, they do their formula, and they say you owe us 1% of the national drug price average. And so now we're going to charge you that amount for each month you didn't have it. So if it was 10 years, you're looking at 120 months times $7 or whatever it is. And then that's your penalty. Okay, so it is important that you have Part D. Yes. Now, if you're enrolled in a Medicare Advantage plan, your Part D is included in that. So you don't have a separate enrollment into Medicare Part D. So hopefully that answers that question. Any other questions on supplements? Okay. So let's talk about the reason why we're here, because that was like the Medicare 101 stuff. But let's talk about the Inflation Reduction Act that was signed in 22. And it kind of hits us full force in the 2025 plan year, okay? So this is legislation that was passed by President Biden back in August of 22. And in this legislation was broad, okay? It was broad. There was a lot in it. But in it, there were provisions for drugs in the Medicare space. So, and a lot of the things that are in that bill, that law, that plan, are good for seniors. Okay, it's good for seniors, but again, with the government doing things, there's not a lot of forethought in how this is going to play out, because they didn't lower the cost of drugs. They just shifted who's paying for them. And so the insurance companies are now paying for the drugs that the seniors were paying for previously. And so the insurance companies have reacted because they got to stay in business. And again, I am an insurance agent, but I don't work for an insurance company. Okay, I work for the 400 people who say, hey, you're my agent. So I work for my clients. I don't work for the insurance companies. But the insurance companies are the ones that are supplying the product for us, right? And so we've got to kind of go with what they give us. But in this legislation, in the Inflation Reduction Act, okay, Part D vaccines were covered in full. So now if you go to get an adult vaccine, the RSV or a shingles vaccine or a COVID vaccine or flu or tetanus, any of those vaccines are now covered 100% in Medicare. You won't pay anything for those vaccines. That happened in 23. Also, the insulin for those who are diabetics was capped at $35 a month. So if you're a diabetic, you will not pay more than $35 a month for insulin, and that's just huge. For people, because those medications were thousands of dollars a year. So that's very beneficial. In 24, what happened is, and I'm not going to get off in the weeds here because this could get complicated, but there was a 4-stage phase category for Part D drug pricing. Once you got through all, and those of you who maybe take higher prescriptions, did you ever notice that as the year went on, your drugs got more expensive? It's because you fell into the donut hole, if you've heard that term. You fell into the coverage gap. And then once you got out of that coverage gap, you were in the catastrophic phase, and you still paid 5% of the cost of your prescription medication. The reason I'm not going to get off on all of that is because that goes away next year. That whole scenario goes away, so I'm not even going to talk about it. But the catastrophic phase this year went to zero. So in 2024, Medicare beneficiaries who hit the catastrophic phase with their drug plans, they paid nothing. So their cost share was zero for the rest of the year. Now, who picked up the cost of that? This year, the government picked up 80% of the cost of that program. And the insurance companies had a 20% cost, all right? Next year, that changes. So in 2025, and this is what this is kind of the crux of everything, all of the changes that we're seeing. In 2025, the donut hole is eliminated. The 4-phase of the Part D drug plan is totally eliminated, and Medicare drugs are capped at $2,000 a year. So no Medicare beneficiary, starting in 2025, will pay more than $2,000 a year for their medications. It's capped. So once you hit that maximum out-of-pocket cost for prescription drugs, then you pay zero for the rest of the year. That is kind of the issue, and that's a good thing, right? Because now I've got clients who are paying $4,000, $5,000, $6,000 a year for their medications. Now, once they hit that $2,000 mark, they're done. All right? So this is kind of the differences between 25 and 24. Because in 2024, and these are averages, the yellow you can't really see, but that is a Medicare deductible, all right? That's a deductible that you pay before the Medicare plan is going to kick in. This year it was $545, and next year it goes up to $590. So that's the deductible, all right, that you're going to pay before the drug plan covers. Now, you say to me, well, I didn't really have any deductible at the pharmacy this year. I didn't notice it. Well, if you're on tiers 1 and 2 generics, those typically aren't susceptible to the deductible. So if you're on a blood pressure medication, or if you're on a cholesterol medication like a atorvastatin or lisinopril, those are tier 1 generics. And they're not generally charged to the deductible. okay? But that deductible is in place. Now you see the averages of the initial drug phase and the donut hole. This year the averages are $3,300 is what people are paying out of pocket, $3,300. Next year that's capped at $2,000. So once you hit that $2,000 mark, you won't pay any more out of pocket. Now, this is very confusing, so I'm just going to make it as simple as I possibly can. No one will pay $2,000 out of pocket for their drugs next year. No one. The drugs, the way they're billing it and the way they're pricing it, let's say you go to the pharmacy and you get a tier 1 generic. Let's say you get metoprolol, heart medication, and that's $0 to you through your plan. Well, the amount of that medication goes towards your $2,000. Even though you didn't pay any money out of pocket, the cost of that medication goes towards your $2,000. So there are going to be medications that you go to pick up at the pharmacy that you're paying very little for that are going to get added to the overall scheme. Okay, so I shouldn't say no one is going to pay $2,000 out of pocket, because I think my example that I have on the next screen shows some dude named Joe paying $2,000. But very few people are going to pay out of pocket for those prescriptions, okay? Part of the Inflation Reduction Act brought about what we call the M3P. So this is the Medicare and then 3 Ps, prescription payment plan. So Medicare is going to give you the opportunity to break your cost for drugs down into 12 equal payments. Again, this is going to get very confusing. And I will say to you, if you are on low-cost medications, you do not want to enroll in the M3P plan, okay? But by the way they bill it, you'll end up paying more each month at the end of the year than you are at the beginning, because as you go through the year and add medications to your list, they're going to break that down over the months of the remaining year. So if you get a medication in July, they're going to break it down by those 6 months, okay? The medications that you got in January were broken down over 12. So if you take low-cost medications and you try to put them in the M3P plan, your monthly bill is going to go up as you go through the year, all right? This payment plan, and it's something that you have to opt into, all right? But I'm just saying, unless you're on high-cost medications, you're not going to want to get involved in that plan. So what is a scenario that would cause someone to want to get in the M3P plan? The example there says Joe picks up a drug at the pharmacy in January. The pharmacy says to him, Joe, the cost of this medication is $850 a month. Do you want this? Have you ever had that happen where the doctors put you on a medication and you went to the pharmacy and the pharmacy said, ooh, wow, this is a brand. It's not a generic. There are no generics. It's going to cost you a lot of money to have this prescription, okay? And then you have to make the choice. Do I get it or do I not? Do I pay for it or do I let it go? Well, in this scenario right here, Joe can say to the pharmacist, $850 a month? Normally he would walk out, but now he can say, yeah, I'll take it. Bill me. Put the bill in the mail. What Medicare will do, what that plan will do, is they will take that $850 medication. It's going to be $8,000 or $9,000 for the year, but he's only going to pay $2,000. So they'll break that down into $167 a month, and he can get that medication monthly. He'll have to pay that $167. All right. I've got a client who's aging into Medicare. she's retiring from her job. She's on a very expensive medication that her corporate health insurance covers at $5 a month. Medicare covers it at a total of about $3,600 for the year. So she's thinking, now I'm going to have to work, right? Because I got to pay for this medication. I can't retire. Well, with this M3P plan, she could, if she wanted, she's still going to pay a little bit more for it, but instead of paying that $3,600 for the year, she could pay $167 a month and still get that medication. Unless you're on a high-priced medication, though, I would not do the M3P. It's going to get very confusing for you throughout the year. And of course, this is brand new, so we don't even know how it's going to work. If you don't pay, who's going to collect? If you can't, if they bill you $167, if you don't pay it, is the plan now going to send a collection agency to collect the $167? We don't know how all of that's going to play out, but I do know that it will get worse for people who are on lower priced medications who would enroll in that plan. So again, it's my opinion. I would just not do the M3P if you're on lower priced medications. So what does all of this mean? And I'll wrap this up here really quickly. We've had a huge shift in the cost sharing of medications starting in 2025. The plans submitted their bids to CMS starting in March and April of this year. Those went back and forth. Typically, they're done by July, June, typically. This year, the end of September here, we're just getting bids back from CMS where they're laying out the cost of what these plans can and will be. The average cost, and I don't want to, I'm not here to cause alarm or to scare anyone, but the average cost of the prescription drug plans went up like 200% during the bid process. So, Medicare told us the average drug plan last year was $35 a month. Really, if you take out some things that shouldn't be in there, it was more like $60 a month. After the bid process went through, the average cost of a Medicare prescription drug plan was going to be like $170 a month. Now, when that happened, and I don't know, again, I don't know how this works, but CMS, which is just a government body, they're not legislatures. I don't know how this happened because Congress controls the purse strings, but CMS dumped $8 billion into the prescription drug market to lower the cost of those plans. So the plans for 2025 are artificially lowered because CMS dumped $8 billion with a B. That's so much. They dumped that in there to lower the cost of these drug plans. The insurance companies typically had 2 to 3 different plans in the drug market. Most companies shrunk them down to 1 or 2. Some companies left altogether. They're not even offering Part D drug plans for next year. Those that are in the Medicare Advantage space, it's a little less painful because the Medicare Advantage plans have the medical side to be able to offset some of the cost of those prescription drugs. So what we're seeing next year, we're seeing higher premiums on standalone drug plans. We're seeing fewer choices. We're seeing stricter formularies. So I have not even seen the formularies on these plans yet. I won't have access to them until next Tuesday. But on Tuesday, I'll have access to the formularies of the plan. So clients who I have enrolled in plans based on their medications, those plans may not even cover their medications next year. So the formularies have gotten thinner. The drug tiers have changed. So plans that had drugs on tier 1 and 2 generics are now on tier 3. Well, tier 3 is a percentage, not a static copay. It's a percentage of the cost of the drugs. So in the review process for our clients, what we do is we take all of their medications and we compare those to the list of all of the formularies that are available in their area, and that's how we choose a plan. So we don't choose a plan because we like Humana or because we like Aetna. That's not why we choose a plan. We choose a plan because that plan works specifically for that member. Have clients call me all the time and say, hey, my sister's with Humana. She loves it. I think I want to go there. Well, let's look and see. Do your doctors take Humana? Are your prescriptions covered in that plan? So there's a lot that goes in the review process. So formularies are getting stricter. There are more drug utilization reviews. Step therapy and quantity limits are all being put in place here. So there's just a lot of changes to the plans. Now, Medicare tells us that typically from year to year, less than 10% of the people shop their plans. And I think that's probably correct because I have got clients who've been in the same plan for 7-8 years. It works good for them. And so if it's not broken, we don't try to fix it, right? Well, this year, all of that changes because the plans have all changed. And so we've got to go back in and we've got to do these reviews. Now, you're saying, well, what do I do? Well, the first place we start is with this ANOC letter. So the ANOC letter is the annual notice of change that gets mailed out each September. So today's the 28th, right? You've received an ANOC letter from your Part D drug plan or from your Medicare Advantage plan. You've received it in the mail already. It probably got thrown out with the junk mail because they mail us so much stuff, right? So we don't know what do we keep or do I stay or do I go? We just don't know. That annual notice of change is going to tell you what changed in your plan for next year. And so it's very important that you read that plan, okay? It's going to tell you everything that happened and all of the changes that took place in that plan. Medications that were removed from the formulary, the price of the plan might have increased. So it's just important that you review that ANOC letter when you receive it, okay? Once you get the ANOC letter, or let's just say you don't, how many of you have read an annual notice of change for this year? Anyone? Did anyone read an annual notice of change for this year?
I got it from Blue Cross, but just a QR code to scan so I can get the details.
Okay, there you go.
It was a very brief letter.
Okay.
And you could scan the QR, which I did not do.
Okay, so the QR code is going to take you to the evidence of coverage for next year, which is a 279-page document, which you're probably not going to read. So let me just make it easy for you, okay? And again, this is not a sales presentation. This is an education seminar, but I always like somebody who knows something to give me the heads up, right? So we do plan reviews with our clients on an annual basis, just to make sure they're in that right plan. So what our clients would typically do if they read the annual notice of change, and I've had a couple of them out of 400 that have, and they've called us and they've said, hey, what do I do here? So those people are proactive, but let's just face it, most people are not going to do that. I wouldn't do that. If I was sitting where you're sitting and some other guy was up here talking, I would probably be asleep right now. I commend you for staying awake during this presentation. If I wore a hat, I'd take it off to you right now. But after you read through that annual notice of change, or if you don't want to read through that annual notice of change, then call us and say, hey, look, this is what I have. And these are my medications, and these are my doctors, and this is what I need. Or if you're in a supplement plan, this is what I'm paying for this plan. Is there anything, better for me out there? We typically do those types of plan reviews. So this slide, again, I don't know if you can read it, but obviously we're here for you. You can schedule an appointment with our office. You can call us. There's our phone number, and call us after you read your ANOC in September. Now, you mentioned QR codes. I think we have some QR codes here. Yep. So we have a QR code here. I don't know if you can scan this. But this particular QR code will take you to a survey that we have. And in that survey, you can list your doctors and your medications. And then we can go and we can check for those medications. Did it work? Okay. I spent 45 minutes on the phone with a client the other day going through her medications for next year. And I certainly don't mind doing that. I love the people that I serve, and I love talking to them. But this app here, it just gives us a very concise way to transfer information as far as your medications go. And then we can do those reviews for you, and we can help you, with the plans for next year. So we've talked about medications. Those of you that are in supplement plans, and I don't know how many of those are here. I know the one lady who was here was in not a supplement plan, but a Medicare Advantage plan. So Medicare Advantage plans are Part A, B, and D rolled into that one plan. And then that plan's going to be operated by a private insurance company. Okay? The difference between those plans and supplement plans is that those plans are typically no cost as far as the premium goes. A Medicare Advantage plan, and they do have Medicare Advantage plans that have premiums, but they're typically $0 are the plans that we go for, because those are the plans that have the most value. So, and a supplement plan where you're paying $150 a month, and then you've got another drug plan for $30 a month, and then you've got the Part D deductible, the Part B deductible that throws in, you're a couple grand a year in cost in those premiums. So with a Medicare Advantage plan, you typically pay $0 for the plan itself, but then you pay for services as you use them. So there's going to be a copay for the hospital. There's going to be a copay for the doctor. There's going to be a copay for specialists. So people who are in Medicare Advantage plans pay as they use the service, where people who are in supplement plans pay up front. So that's how it's billed. You're going to get close to the same services, but you're going to pay for it differently. Now, in Medicare Advantage plans, there are these gaps in coverage where you're going to pay a copay at the hospital. It might be $350 a day for days 1 through 5. You might have an outpatient procedure done, and the copay for that might be $240. So how do you pay for these copays? Well, most people are just going to pay out of pocket. Hospital indemnity plans or recovery plans are plans that cover those coverage gaps. So we can pair a hospital indemnity plan with a Medicare Advantage plan for pennies on the dollar versus the cost of the supplement. And we can get them close to the same coverage that they would have, because you're looking at covering those big out-of-pocket costs, those hospital visits, skilled nursing, if you had rehab, therapy visits. All of those are included in a hospital recovery plan. There's also cancer and critical illness riders. Now, I'm a lousy salesman, okay? I don't push hospital indemnity on my clients, but I always feel bad when they call me and say, man, I spent a week in the hospital and I got a bill for $2,000. Because I kick myself because I say I could have helped them get cash for that bill for $30 a month, but I didn't talk to them about hospital indemnity. This year, with the way there's so many changes, we're throwing hospital indemnity in the education presentation because we feel like people should know there is an option for you to help cover some of these costs. They have cancer and critical illness riders included with them. Again, cancer and critical illness is something I have access to. I just don't sell it a lot because I don't talk about it a lot. But when I see that 1 in 3 women are going to get cancer, and I see that 1 out of every 2 men are going to get cancer, and my client calls me up 2 weeks ago and says, I just got diagnosed with cancer, I'm kicking myself because, you know, for just a few dollars a month, I could have got them a cancer plan. So those are things that you can certainly look at in the area of hospital indemnity. Very quickly, and I'm going to wrap this up, dual special needs plans for those that are on both Medicare and Medicaid. There are dual plans where you're going to get additional benefits. So when you're watching the TV and Joe Namath says, hey, look, you need to call me to see if your zip code qualifies you for $3,000 a year in additional benefits. Those are typically dual plans for people who have both Medicare and Medicaid. But if you're in that category, a dual plan is going to be very, very good for you. But once you call Joe and you say, hey, look, I want to see if I qualify for the $3,000, well, now you've invited him to talk to you. And before you leave that call, you will be in another plan. Okay, it just happens that way. Chronic special needs plans are also something that the last couple of years have come out. If you've got heart, if you've got diabetes, there are chronic special needs plans. You can actually enroll in those plans 12 months out of the year for people who have those chronic conditions. Dual special needs plans, if you're in that space, if you're in a dual plan, you've enjoyed a quarterly special enrollment period over the past years. That goes away next year. So there are no special enrollment periods for people who are in dual plans to switch to another plan. Chronic special needs plans you can enroll year-round. Finally, the low-income subsidy. So the low-income subsidy is also called extra help through Social Security. If you are a single person and you make less than $22,590 a year, if your income is less than $1,882 a month, you're going to qualify for that low income subsidy. If you're a married couple and you make less than that $30,000 figure, you're going to qualify for a low income subsidy. What does the low income subsidy do? Number one, it lowers the cost of your prescription medications. You're going to be paying in the $4 range for generics. You're going to be paying in the $10 range for brands, no matter what the cost of that medication is. You also have late enrollment penalties that are waived. And it also covers the cost of your premium for the prescription drug plan. So there are a lot of benefits to that low income subsidy. Again, if you fall in those ranges, the application there is certainly something that we can help you with. Again, this is the QR code that sends you to the survey where you can add medications and doctors for us to do a plan review. There's our phone number there, 248-648-1802. You can call us. You can email me, david@bowenig.com. QR code take you to our website and also to our Facebook page, which we're trying to grow. I think that's it. Is that it, David? So I'll go ahead and leave that up on the screen. Again, thank you. I think I was more than an hour. I tried my best to plow through this information. I think the thing that we take away here today is that you need a review of your plan for next year, no matter who you are. If you have a trusted insurance advisor, call that person and say, hey, look, what am I in the right spot? Okay, reach out to that person. If you do not have anyone, we're certainly here to help you and would love to help you. But you need to do a review for next year. Medicare tells us again that this plan year coming up with all of the changes, they're expecting 70% of people to shop their plans because there's going to be so many changes. Those that don't shop their plan, haven't read their annual notice of change, they're going to be surprised in January when they get their drug plan bill, or when they start visiting the doctor and find out, that drug is no longer on the formulary. So it's going to be very important to do a change for this year. Again, Medicare does not allow us to cold call people. If we've said something here today that has piqued your interest and you'd like to talk to us further, and you haven't scanned the code, you can sign one of these forms right here and just give us your phone number. What that does is it just means we'll give you a call and see if we can help. So we don't cold call people, but if you want to speak to us, you can fill out one of these forms. Thank you, sir.
Well, let me just simply say I got a couple of questions that came to me in text. But I did this a couple of years ago, and I went on YouTube, I looked through videos, and I just look at it this way, it's trying to find a needle in a mud puddle. It's a nightmare trying to figure all this out, and having somebody that can navigate it for you and with you. I ended up reaching out to the guy that covers my homeowners and asked if they had somebody, and they said, yeah, we have a Medicare professional, trying to deal with them over the phone. And at the end of the day, they didn't really answer a whole lot of my questions, other than I was told by a family member that, that went through all this, that, you'd be better off to have G. And I went with G. It's a monthly premium. And I can say on the backside of having a heart attack that since that was a good move on my part. I just tell you that, because I think that Part B deductible is $240. That's all I paid this year in and out of the hospital, therapy and whatever. So it was a good investment for me. The indemnity thing, I think, was a good part to think about and to bounce off, whether you pick up a supplement plan. But the question was, let's see here. First one was, can you change insurance companies to a less expensive company? And what is that period? Is that now, or is that the one that starts in January?
Okay, so can you switch your plans? So it depends on the plan that you're in. So, Pastor, you give the example of Plan G. So if you're in Plan G, you can change that plan at any time throughout the year. The only thing is you have to go through medical underwriting. You have to qualify medically to go from one plan to the next. But you can change that plan at any point throughout the year. If you're in a prescription drug plan, or if you're in a Medicare Advantage plan, then you can change that plan during the annual enrollment period. During the annual enrollment period, you can change that plan multiple times between October 15th and December 7th. You can enroll in multiple plans. But whatever plan you've enrolled in at midnight on December 7th is the plan you'll have on January 1st. The same thing with drug plans. During the annual enrollment period, you have that opportunity to enroll in a drug plan for the next year. During the open enrollment period, you can only switch once from one Medicare Advantage plan to another, or you can disenroll from Medicare Advantage and enroll in a prescription drug plan. But the open enrollment period is one plan. It's a one plan option. So supplements 12 months out of the year, Medicare Advantage, prescription drug plan, you're looking at the annual enrollment period, October 15th through December 7th.
I think you answered this question. The CMS, that sounds like an arbitrator between the drug or
So-
to the insurance companies and the government that negotiate.
So CMS is Medicare. CMS is the Centers for Medicare and Medicaid. So it is a government agency. Healthcare.gov, all marketplace plans run through CMS. All Medicare plans run through CMS. So Centers for Medicare and Medicaid.
Okay. I have another question. I'll have to call them on the phone and let them kind of ask that. Is this okay that we take a couple questions and answers? I'll get you on. I'll put you on the microphone so that those that are online watching can benefit from that. Yeah, I can just simply say I think we can all see the benefit of having somebody help you work through this. This is a nightmare. I'm just telling you. So I guess we could just thank him for coming and doing this.
Thank you for
for us here
allowing
today
me.
for first and
I
foremost.
appreciate your time today. Absolutely.
Anybody else have a question?
Hold on, you're not near you.
I heard David Bowen last year. He was at our church, and I worked in medical billing for many, many years. He's extremely knowledgeable. He knows a lot. So my question would be, with all the prescription changes, that seems to be the major change coming for 25. Do you see, is it still going to be zero copay for the Medicare Advantage plans, or do you see an increase in the future, or?
I don't
what do you
think $0 Medicare Advantage is going away anytime soon. Okay? What we're seeing in the Medicare Advantage space and the drug plan space, and again, the cost of these drugs, because the insurance companies were picking up 0 2 years ago. This year they picked up 20%. Next year the insurance companies pick up 60% of the cost of these drugs. So they've had to go in and change everything. So we're seeing some decrease in benefits in some plans. We're seeing deductibles where we didn't see them before, a medical deductible or a health deductible, and not in all plans, but we are seeing it in some plans. And then what's the big question mark for us, and we won't know this until next week when the plans are released, but the big question mark is the formularies. Because we do know that plans have told us that they've removed drugs from their formulary completely, and that they've moved them from tier levels. So people who were expecting to pay 0 or $5 a month, that drug might be on a tier 3, where now you're paying 40% of the cost of that drug. So that's kind of the big thing that we're seeing right now. But all of these are driving cost. This whole drug question is driving cost in these plans. So, yeah, hopefully that answers the question.
Now you're like for me, for my supplement, which would be called an Advantage plan, but usually when they're advertised on TV, they're pushing C. But you say that's off the table now.
No, Medicare Part C is Medicare Advantage,
Okay.
and those are the commercials you're seeing, okay? You typically don't see commercials for supplements. So,
But you can actually run into trouble in C, like in the donut hole and stuff, and end up costing you more than some of these other plans.
you know, not necessarily, because Medicare Part C, again, is Medicare Advantage. What we typically see in Medicare Advantage is that the drug prices in a Medicare Advantage plan are going to be less than the drug prices in a standalone Medicare Part D drug plan. And the reason is, if you're in Medicare Advantage, then that company has the ability to hide some of the cost of those drugs in the medical side. Whereas a standalone drug plan, and this is where we've seen tons of changes for next year, a standalone drug plan just offers drugs. So they don't have any place to hide costs.
But you have to pick that or an Advantage plan.
Yes, you have to have one or the other. Yep.
Okay, that I understand.
You have to have a Part D drug plan. Now, there's some instances where people don't. If you're a veteran and you use the VA for your prescriptions, you don't need a Part D drug plan. Okay? So I have a lot of clients who are veterans, and we have plans that are built specifically for veterans that don't include drugs in the cost of those plans, and so they can add additional benefits to them. So there are some circumstances where you wouldn't have a Part D drug plan, but most people are going to have it.
Any other questions? I'm just asking questions that ran through my mind. Tim, let me get back here and get you on here so those online can listen.
Kind of struggling trying to understand the difference between a supplement and an Advantage plan.
Yep. So with a supplement plan, you have original Medicare Part A and B, and then you're going to go out and purchase a Medicare supplement plan to cover that 20% copay. So somebody who has original Medicare Part A and B and purchases a supplement plan from an insurance company, you're going to also purchase a Part D drug plan. So you're going to pay Medicare, the $174.70, and then you're going to pay a premium to the insurance company that you choose for the supplement plan. And then you're going to also pay for a Part D drug plan. And then that's going to build your health care coverage. So you have Part A, Part B, Part D, and then you have a supplement that's going to cover that copay. I think that's the scenario that the pastor is in right now.
I don't have C. I have A, B. I have D, which is Silver Script.
Yep.
And then I have G,
Which is your supplement.
which is my supplement, which is a premium. And some people, if you're healthy coming into Medicare, you say, well, I'm not seeing the doctor. I really don't have medical issues. So that 20% is really not a big issue for you. But somewhere down the line, you do get sick. Hence, like what happened to me. I didn't have the 20%. I still have a monthly extra. But now, if I wanted to get into G, I have to go through a medical. See, coming into it, I think you come into on
Guaranteed
a base
issue.
rate. It's
Yeah.
It's a guaranteed in whatever
So when
that
you
price
age in,
is.
when you age into Medicare, you have a guaranteed issue period, okay, that's going to surround that 7-month initial enrollment period that you have. 3 months prior to your birth month, 3 months after. During that time, you can enroll in any Medicare supplement plan without any health questions.
And
So
it's
you
all
can
the same
literally
price,
have
correct?
stage 4 cancer and enroll in a Medicare supplement
At
plan.
the same price that I did.
Yeah.
No.
Now the difference, you asked what is the difference between supplement and Medicare Advantage. So in Medicare Advantage, it's Medicare Part C. And Part C is A, B, and D rolled into that one plan. And then that plan is operated by the private insurance companies. In this area, again, I think I looked at 7 companies offering Medicare Advantage with like 46, 47 different plans. Again, those plans, we typically would choose a $0 premium, so you wouldn't have any additional cost to go into the plan, where the supplement plan, you're going to be paying,
138, I think, was what we pay.
so you multiply that out by 12, and then you throw in the 240 Part B deductible, and then you add on the drugs. You're about $2,000 a year in the cost of that route. In a Medicare Advantage plan, you pay $0, but then you would pay as you would use the services. So those that are healthy and don't visit the doctor a lot in a Medicare Advantage plan, they're not paying anything. My grandmother, we had her in a $10 premium Humana plan for years. She went to the doctor once a month, had a $10 copay. Her health care literally cost her $120 a year. So that worked out for her. In a situation where where you're sick, if you have cancer, if you end up with a heart issue, and you've got to go to the doctor in the hospital, then there's going to be services that are billed through those plans, okay? And then you pay those copays. And that's why we talked about the hospital recovery or the hospital indemnity, because that kind of helps ease the pain of some of those copays. Now, I will say this, and I don't have a preference, okay? I don't promote a company. I don't promote a plan. Every client I have, we build their plan out individually based on their needs, okay? But what Medicare tells us, and the differences between supplement and Medicare Advantage, is that people who are in Medicare Advantage plans statistically pay less for their health service than people who are in supplements. And the reason for that is if you're in a supplement plan, you're paying for that plan whether you're using services or not. If you're in a Medicare Advantage plan, you're only paying for the services that you need. Now, I talked to the guy last week, actually it was a couple of days ago. He's having the neck surgery. He's in a Plan G, and he said, man, I'm so glad I'm in this plan because my doctor said $80,000, 80 grand. And I said to him, how many days are you going to be in the hospital? He said, I'm going to be in the hospital just a day. The doctor's telling me I'm going to be in the hospital a day. I said, well, just so you know, if you were in a Medicare Advantage plan, that $80,000 neck surgery would cost you $325 because you're in the hospital for a day. So the daily hospital copay in a plan, $325 a day. So it covers everything that happens to you in the hospital that day. So no extra doctors or surgery or nothing gets charged extra. So it's $325. I've got another client who had an outpatient hip surgery done 2 years ago. The outpatient procedure copay was $140. So he had a $13,000 hip surgery and his cost was $140. And that was in a $0 Medicare Advantage plan. So again, you're getting Medicare Advantage has to cover at least what original Medicare covers. It has to cover at least what original Medicare covers. The only difference between the two plans is how you pay for them. If you're in a supplement plan, you're going to pay up front. If you're in an Advantage plan, you're going to pay as you go.
Good explanation. Anything else? Other than that, thank you for coming. I'm going to let you talk to him directly. I'm going to see if I can get this one question on the phone, and well, let me see if he has. Let me just text real quick and see if there's a question out there first. Anybody else have one while I'm doing this?
Yes.
Yeah, I have a question. question. Where do they come out with the tiers? Tiers 1, 2, and
So drug plans typically are going to have tiers 1 through 5. All right, tiers 1 and 2 are going to be, tier 1 is going to be, the low-cost generics.
okay, 'cause that's
Did you
what
have one?
tier 1.
Tier 2 are going to be less popular generics, but tiers 1 and 2 are typically a $0 deductible on most plans. Tiers 3 are brand drugs. Those are typically billed at a percentage, 30, 40%. Tier 4 is going to be specialty drugs. And then tier 5 can be a variety of things. But the higher up you go in the tier, the more you're going to pay for the medication.
Will we always stay, we're Blue Care Network Advantage is what we are, and we're at tier 1. Will we stay at tier 1?
That's a very good question, and I'll know the answer to that on Tuesday. Again, Medicare doesn't allow me to talk about plan specifics prior to October 1st. And that's when all the plans release their information. And I don't have all of that information yet because of the turmoil we've been in. I've probably been in 25 to 30 certification meetings since June of this year, just trying to get ready for 2025. But next Tuesday, they open the gate and we get all of the information. So we can do a plan review and check your drugs to see if there were any tier changes in those plans. Again, all I know is that the plans have told us that they've removed medications, they've changed tiers on some. Hopefully your tier 1 and 2 drugs are still tier 1 and 2. But on Tuesday we can put those through the system and it will tell us. And again, I am contracted with everyone out there, probably 50 different insurance companies, and I don't have a favorite that I push. I just, whatever the information gives us. When we do a plan review, we're going to check your medications. We're going to check your doctors to make sure they're in the network. Once we get medications and doctors covered, then we start looking at additional benefits. So once we get your medical assured, then we can say, hey, this plan has more benefits than that plan. And there's many times I do a review for someone and I say, hey, you're in the best plan available, so you need to stay where you're at.
Well, we like what we got, and we are very
Sure.
happy with how it works.
Sure.
We get it through GM.
Okay. Yep.
They help pay that $100 premium.
Yep. So if you are in a, I tell retirees, typically if you're in a retiree plan, you are in the best plan you could get because you're in a group plan and you have that law of large numbers working in your favor. So if you're in that style of plan, you're probably in the best plan.
Thank you. That helps.
Yep.
Okay, I've got a question here for you real quick. I've got Bob on the line here. Go ahead, Bob.
I've got a question on your Advantage plans. Do they typically have limits to where once they spend so much money, you're cut off?
So Medicare Advantage plans do have a maximum out-of-pocket cost limit. Is that your question?
Out of pocket, Bob, or is you talking about how much you are costing
Coverage.
them?
No, I'm talking coverage. Say I was in the hospital, had a bad heart experience, and my hospital bill's $500,000. Do they only cover maybe up to $300,000 and then you're done, or how does that work?
Okay, let me-
I've heard in the past that has been an issue.
Okay, so no, there is no limit.
No limit.
Bob, there is no limit on what the Medicare Advantage plan would cover. They will cover the bill in full, and then they will charge you accordingly. Now, a Medicare Advantage plan will have a maximum out-of-pocket cost associated with it. And since we're in 24, let me just give a 24 description, okay? And I'll use Blue Cross, all right? And this is the plan that I'm using right now this year. So this is all public information. I'm not violating any CMS rules at this point, but a Blue Cross PPO plan, a Medicare plus Blue PPO plan, has a $5,200 out-of-pocket cost, okay, maximum out-of-pocket cost. Blue Care Network HMO plan will have a maximum out-of-pocket cost of $4,500. That means you'll never pay more than the $4,500, or you'll never pay more than the $5,200. Now, Bob, give me a scenario here, because you said if I go in the hospital and the bill is $500. How long are you in the hospital?
500,000.
No, I'm talking hundreds of thousands of dollars. Obviously, you go into the hospital today, you can run up $1 million bill.
Okay.
Are these companies going to pay, or do they have a limit? Say, once you reach this limit, we're no longer going to cover you.
No, there is no lifetime limit on what they would pay. A Medicare Advantage plan has to cover at least what original Medicare pays. Okay? So I do have a client who 2 years ago had serious health issues. She had over $1 million in hospital bills. Her maximum out-of-pocket cost in a Medicare Advantage plan would be $4,500, or would be $5,200, depending on the plan. So no, there is no cap on what Medicare Advantage covers.
Okay.
They're going to pay the bill in full.
How
Premiums, is there a limit to how much your premiums can go up, or can they go up based on your usage?
No, they're not billed by usage. The premium in the plan is based on whatever the plan is. If you're
So
in
no matter
Medicare,
how much you've used it in the last few years, you won't go up any more than somebody that doesn't use it?
that's correct. Yep.
Okay.
If you're in,
Now, one other question.
Sure.
What if I'm on vacation and I'm out of the area and I'm only supposed to use a certain doctor or certain hospitals? I think Advantage plans require you to use their in-network people. What happens if I'm, say, in Florida and my network's up here and I have a problem?
okay, so if you're in a Medicare Advantage plan and you're traveling outside of your service area, then you're going to go through the emergency room for any services you need. Because no matter where you're at in the country or in the world, Medicare Advantage will cover you in an emergency as if you're at home in network. Okay, so if you're traveling and you're in an Advantage plan, you're going to go through the emergency room. Now, there are Advantage plans, and again, I'll talk about a 24 plan here, and I'll use Blue Cross. Blue Cross's HMO plan, their BCN plan, will cover you in Michigan at 100%. It'll cover you in Florida, Texas, and Arizona at 100%. It's their snowbird coverage. So you can see any doctor that's in the Blue Cross network in those 4 states. If you're in any of the other 46 states, you go to the emergency room, and those doctors are covered in network. Now, if you're in a PPO plan, you get coverage in all 50 states, and you see any doctor in the Blue Cross network.
Okay. I have one other question that's specifically to me, though. I don't know if you want to cover it in front of everybody, but I have a Cigna Plan G supplement plan.
Yes.
And I'm just going to read you something. A Medical Containment Life Insurance Company, a wholly owned subsidiary of Cigna Group, has agreed to replace Cigna Health and Life Insurance Company as your insurer under Medicare supplement policy. Medical Containment Life Insurance Company's principal place of business is One Expressway. That gives you that information. Why are they doing this? Have you heard of this, and what's going on with that?
You know, I don't know the answer to that question. It could be a company within the company, and they're just carving some stuff off for certain reasons. Sometimes I know Aetna has 3 or 4 different companies, depending on your what area of the country you're in. And so you might be with Continental Life, you might be with Aetna, you might be in another Aetna subsidiary. So that particular one with Cigna, I haven't heard yet, but I can find information out about that if it's important to you. Yes.
Could you do that? Because I have to sign, and my wife's going through some issues right now, and I hate changing companies or changing anything while we're in the middle of some procedures. You know what I'm saying?
Sure. I will tell you this, just to give you a little bit of peace of mind, and I'll certainly check this out. But if it's a company that has a contract with CMS, and they're offering that Plan G, you're not going to have any coverage issues if they've moved that to a different subsidiary. It's just not going to happen.
Okay.
You're not going to have any coverage issues if they're changing the name of what they've enrolled you in.
Because G is G.
G is G is G is G.
Okay. All right. Good to know. That had me worried.
Yeah, I tell you what, I wouldn't worry about that too much. But if, again, I can certainly, I have access to all the information. I can certainly look at it for you, Rick.
If you could just check that out and let Pastor Rick know about it, and
Sure.
He'll let me know what's going on.
I'll hook the two of you up. I'll get you together. I do have one other question here. It says to switch insurance companies on a regular supplement plan, do you have to go through Medicare underwriting?
Yeah, which means that now that they're going to get pre-existing conditions that fall, correct?
So, is it a supplement plan?
It says to switch insurance companies on a regular supplement plan, do you have to go through Medicare underwriting?
Yes.
Yes, the answer to that one is yes.
Yeah, which means they take into account your health issues and that adjusts your premiums more than likely, I would imagine.
Correct.
Right.
Now here's something else. All right, and again, this is education. Let's say you're in a Medicare supplement plan and you've had some serious health issues, but you're in a plan where the rates have kind of went up high, and you really don't have an option to move because you're not going to qualify medically. Medicare gives us a once lifetime trial right period to leave a supplement plan and go into a Medicare Advantage plan. And then you can stay in that Medicare Advantage plan for up to a year. And if you don't like the Advantage plan, then you can go back to a supplement plan, guaranteed issue, without any health questions. So I have had clients who wanted to move, and we moved them. Once most of them get to Medicare Advantage, they stay there. But last year I had two people who left supplement, went to Medicare Advantage, was in it a short period, and then they moved back to the supplements. Well, when we moved them back, we were able to get them into a plan with a better rate. But then they've used that once lifetime trial right period. So there are loopholes that we can use to move people from supplement plans who don't qualify.
But you can only do it one time.
Once in your lifetime. Yep. So make it a good one. Make it a good choice.
Well, I think David Bowen has painted a scenario that it's very, very important to have somebody look over your scenario to give you the advice to do whatever it is that you need to do. And am I correct on that? I know that sounds like you're selling yourself, but it's just, I'm just telling you, like, I know that Brother Eastman here, he's just getting ready to age in, and
you are getting hammered right now.
It's more ways than you can imagine.
You dread going to the mailbox, pulling that pile of mail out.
It just helps to have somebody, because this is just crazy to try to figure out on your own. It really is.
Well, there's a lot of moving parts to Medicare, and I don't know all the answers to everything, but I do know someone who knows the answer to that question. So whatever the question is, we can find an answer for you. If we don't know it at the time, we'll find the answer for you.
Now, to call you and to have you do this service, you become their agent. Is there a fee on our part, or does Medicare take care of you for signing people up? How does...
Yeah, so I have 400 clients. None of my clients pay me anything. I'm paid by the insurance companies. And I'll say this, everybody pays the same. There's a standard fee that comes with Medicare Advantage and Medicare Supplement. So I have no financial incentive to move you from one company to another.
Do you take tips?
Well, there's no tax on tips, right? So yes. No. Yeah. So and here's the thing. So if you become my client and let's say we use a company and that company pays me. Next year, they're going to pay me again to keep you as that client. So I have a financial incentive in making you happy. Because if I put you in the wrong plan, or if I put you in a bad situation, then you're going to leave me. And that doesn't do me any good, and it doesn't do you any good. Well, it might do you some good. But so Medicare pays me annually for all of my clients. So I'm on the clock for the people who are in my space, working for them and answering questions. And my clients will text me or call me and say, "Hey, sorry to bother you." You're not bothering me. That's why we're here. We're here for you to bother us. Yeah, Medicare and everything is just a standard. It's just a standard fee. So again, I collect no money from my clients, and Medicare pays me for having them.
If I'm doing the math, out of my Social Security check comes out Part B, which is $178. It's that somewhere in there.
$174.70.
$174.70. That's an automatic for all of us.
Mm-hmm.
If I go with a C, it's zero out of pocket and pulls in D, which is costing you say $35 a month. And I only have to pay if I use the system by a percentage, that 20%.
Not even by a percentage. Most Medicare Advantage plans have static copays.
Oh, copay.
Yep. So there is the only time you're going to run into a percentage if there's a cancer situation and you have a 20% copay on most chemotherapy drugs because they're billed under Part B and not Part D. But most Medicare Advantage plans just have standard copays. Now, again, I only know what my clients tell me, okay? I had a client, and in Medicare Advantage, Medicare Supplement, what's best? People will say, well, which is the best plan? And I'm like, there's no way to tell you which is best. You have to do what works for you. I had a client who was in Medicare due to disability. He was in Medicare for 13 years. He aged in 2 years ago, so he turned to 65. So that means he had Medicare at like 52. So when he turned 65, I called him and I said, "Hey, do you want to look at a supplement? Because you have guaranteed issue for the next 7 months if you want to move to a supplement plan." And he said, "Yeah, I'd like to look at that." Well, when I quoted him the price, I think I quoted him that $130 that Blue Cross had at the time. And he said, "Okay, $130 times 12 plus the $240 plus the Part D." He did the math in his head real quick. He says, "That sounds like $1,700 a year." And I said, "Yeah, pretty close." And he said, "I've been in Medicare Advantage for 13 years. He said, "I've never had a year where I paid $1,600 in copays." Again, that was his viewpoint and his testimony to me. So he said, "I think I'll just stay where I'm at." So I was giving him the once lifetime shot, to get in without any medical questions.
But if things go crazy, then to get into G or one of those supplements is based on your
health
qualifications.
Yeah. So he said, no, I'll stay in Medicare Advantage because I have not had an experience where I've paid more in co-pays than I would pay in premiums to be in G. Again, Pastor Rick, that was his that was his experience. I've had clients who got into a supplement plan when they turned 65. Within a few months, developed cancer, lasted 3-4 years, never paid more for the services than their premiums. So it was just the premium is all they paid. So in that regard, that plan worked good for that person. I mean, you had a heart attack last year. That plan that you're in worked good for you. I do tell my clients, though, who can't afford supplements to not be afraid of Medicare Advantage, because you can through hospital recovery plans, build a package that is almost equal to the coverage. Instead of paying $50 a month, you can get that for $35 a month.
Wow.
So
does that work with cancer as well?
Yeah, so that's where we talked about those cancer riders, in those plans, because again, when you're in a Medicare Advantage plan, you're looking at the driving costs that could get you to that maximum out-of-pocket cost, right? So the cost would be hospital copays, $300 plus a day. Skilled nursing, first 3 weeks are no cost, but after that, you're looking at $200 a day. There are Part B drugs, that could be 20%. So there are some costs that could drive you to that maximum out-of-pocket cost of that plan. But once you hit that maximum out-of-pocket cost, if you did, then you wouldn't pay anything. Now, Medicare tells us less than 3% of Medicare beneficiaries that are in Medicare Advantage hit that maximum out-of-pocket cost. So far, I've only had one person in 10 years out of 400 clients hit the maximum out-of-pocket cost in their Medicare Advantage plan. I was on the phone with a guy the other day. His mom was in a Medicare Advantage. She had went through cancer last year. Her out-of-pocket cost was like $1,500. This guy was an agent. He moved his mom into the Medicare Advantage plan off a supplement plan, to save her the premium. In a cancer situation, he said she paid less than $1,500. So again, it's cats and dogs. Do you like cats or do you like dogs? I mean, it's just a different way of paying for the services that you're going to get. And like with insurance, it's a gamble. I mean, I pay my insurance premium to but hopefully I don't have to use it. It's just a gamble. But whatever you feel comfortable with.
Any other questions?
I think another thing about the Advantage plans, they do offer dental and hearing and vision coverage.
Yeah.
You don't have that with the others, do you? Unless you're carrying a...
Well, you buy a separate policy. Yeah.
But, man, the dental coverage alone has been a benefit to me.
Sure.
And then Blue Cross plan offered the option to pick up another $20-some a month to give you a $3,000
Right.
dental benefit for the year, which is a lot of coverage. Talking to other people, my sister-in-law worked for the county of Saginaw, and she has no dental coverage. She's paying a lot out of it. Anyways, there are
Yeah.
some, like you say, you gotta weigh the advantages and what works.
Yes, sir.
So, I'm gonna turn 65 in February.
Okay.
I'm still working my
Okay.
job, and I have Blue Cross insurance. So this is like in addition to your
Yeah, so Brother Eastman, what would happen for you? You have Blue Cross as an employer benefit right now?
Correct.
Okay, so what's going to happen for you when you turn 65? Will you work past 65?
Oh, yeah.
Okay, so you're going to continue working. So your HR, I would reach out to your HR department. I would reach out to HR and say, hey, look, I'm going to be 65 in February. Do I take Part A? So Part A comes to you premium free. You don't pay anything for that. You've already bought that in advance. That's your hospitalization coverage. Typically what employers will do is they'll move their employee into the Medicare Part A, but you won't take Part B. So your hospital coverage will be through Medicare, and then your medical would stay with your employer. So, and your drug coverage would stay with your employer. So as you age into Medicare, you would incur no additional cost. All right. Now, where that scenario changes is if you pay out of pocket for your corporate health insurance. If you contribute towards that, then you have to do the math, okay? Because I do have employees that contribute towards their corporate health insurance. And so then you got to decide, well, if I take Part B, then the 174, is that less than what I'm paying for my corporate health insurance? And if it is, then you may want to forego your corporate health insurance and enroll in Medicare. If you're not paying out of pocket for your coverage, then you're going to want to stay with your corporate health insurance until you retire. And if HR doesn't require you to enroll in Part A, if they just keep you on, then you wait until you retire. And then once you retire, Medicare is going to give you an 8-month window to enroll in Medicare Part A and B and start your Medicare coverage without any penalties. So in your case, you don't have to worry about late enrollment penalties if you have corporate health coverage. The key word here, and this is something for you to ask HR, is our drug plan that's offered to us considered credible coverage through Medicare? If your drug plan is not considered credible coverage through Medicare, then Medicare would require you to enroll in a Part D drug plan when you turn 65, whether you're working or not. But it sounds like you have a Blue Cross plan. I'm sure the drug plan's credible. But credible coverage is the key word you're looking for. That's the word that's going to decide whether you would have a late enrollment penalty when you elect Medicare. And as you get closer to that, if you have questions, holler at me.
Anybody else?
Thank you so much for staying 2 hours now. Wow. Thank you so much. I appreciate your time. Hopefully I've answered some questions in your mind. If not, if you have additional questions, you can always reach out to us, okay?
Thank you, Brother Bowen. Appreciate it.
Thank you.